All right,
Okay.
good afternoon, everyone. I am Shritika Thapa. Welcome to our Yale Sleep Seminar. And just a few brief announcements before I introduce today's speaker. Just make sure you're muted. And in order to receive your CME credit for attendance, please see the chat room for instructions. I have the pleasure of introducing Dr. Dayna Johnson today. She is an assistant professor in the Department of Epidemiology at Rollins School of Public Health at Emory University. And she's also a member of the Cancer Prevention and Control Research Program at Winship Cancer Center, the institute there. She earned both her Master's of Public Health and Master of Social Work degree from University of Michigan, and then got her master's degree in Epidemiologic Science and PhD in Epidemiologic Science as well. Sorry, from University of Michigan. Dr. Johnson then completed her postdoctoral fellowship at Harvard Medical School in sleep and circadian disorders in 2017. Her research is aimed at understanding the root cause of sleep health disparities and their impact on chronic diseases by addressing the social and environmental determinants of sleep disorders and insufficient sleep, and also investigating the influence of the modifiable factors such as sleep disorders and disparities in health outcome, more specifically the social contributors to racial, ethnic, and gender disparities in sleep by quantifying the contribution of social, household, and neighborhood level factors with objective and well-validated measures of insufficient sleep. She's also received many awards, is the recipient of several grants from NIH, and has authored over 100 publications. She also holds leadership position in many national societies. And without further delay, thank you so much for being with us today. I will hand it over to you to share your expertise on addressing sleep health inequities.
Thank you so much for that kind introduction. I also really appreciate the invitation to present some of my work. And again, my apologies for some of the technical difficulties, but can you see my screen?
Yes, we can.
Yes, okay, great. So I'm really excited to share some work that we're currently working on within my research group, which some of it is looking at determinants of sleep health inequities. And another piece of it is really focused on how to address sleep health inequities, particularly with the focus on interventions among minoritized populations. So here's the disclosure accreditation slide. So I'll leave it here for a second in case someone needs the text number. Okay. And so there are a few points that I'll make during the presentation today. And so first, I'll talk about some of the empirical data around racial and ethnic and socioeconomic sleep disparities, with really focusing in on that intersection. So using an intersectionality framework about how both racial and ethnic factors, in addition to socioeconomic status, can interact and really produce inequities that are not what we are used to in terms of the gradients. And so then I'll also talk about some of the multi-level contributors to sleep health disparities, just giving an overview with really focusing in on stress as one of the main contributors to sleep health disparities. And then lastly, I'll share some preliminary data from an intervention that we have, which focuses on mindfulness as an avenue to address sleep health disparities. And so as mentioned during the introduction, I am an epidemiologist. I sit in the School of Public Health. And so a lot of my work is focused on understanding sleep at this population level. And so it's really nice to see that their Healthy People 2030 has expanded in terms of the sleep priorities. And so I'm going to put up each of the initiatives and really think about, and I want you to think about how we're addressing these and the ways in which our work should really be focused in order to address sleep health across the population, but specifically among populations that are most at risk. And so the first one is to decrease the rate of motor vehicle crashes that are due to drowsy driving. And then there's an aim to increase the proportion of adults with sleep apnea symptoms who get evaluated by a healthcare provider. And so I emphasize adults because this is a specific population that they're focused on. However, we do know that sleep apnea, which I'll show some data, it's also very prevalent among younger populations, but the emphasis here is on adults. And then increase the proportion of children, high school students, and adults who get enough sleep. And then increase the proportion of infants who are put to sleep on their backs. There have been a number of campaigns across the years, and we have seen quite an increase in infants who are put to sleep on their back, with a decrease in the number of SIDS events. So this is really a great example of a public health initiative. And then increase the proportion of infants who are put to sleep in a safe environment. And then lastly, increase the proportion of secondary schools with a school start time of no earlier than 8:30 a.m. So these are great, but as I highlighted, there are specific groups that are missed in some of these goals. And then from a health equity perspective, that's really missed here. And so I really want us to think about how this can be expanded as I go through the work that we're doing in the area of sleep health inequities. And so again, as an epidemiologist, I really focus a lot on understanding the prevalence of different conditions in the population. And so we know that sleep disorders and some dimensions of sleep health are highly prevalent, but yet they are largely undiagnosed. And so we see insomnia affects about 30% of the population. And then for sleep apnea, typically affects about 5 to 6% of the population. But I put this range of 6 to 40% because this is a great example about how variable the prevalence is across different populations. So we see among some minoritized groups, such as African American, particularly some of the data we have from the Jackson Heart Study, the largest study of cardiovascular disease in the United States among Black adults, we see that about 35% of that sample has moderate to severe sleep apnea. And when we look at least mild sleep apnea, we see about 70% of the adults, so it's about 30 or about 1,000 participants that were a part of that study. So we see for some of these groups that the prevalence is actually quite higher and very different than what we see as the average across the population. And then for periodic limb movements or restless leg syndrome, affects about 10% of the population. And then for circadian rhythm disorders, it's estimated about 3% of the population are affected. However, there's really a need for more research in this area. And so I believe that the estimates are probably much higher than this, but due to the lack of population level assessments, it's a lower percent that is reported. And then we see short sleep duration affects about 40% of the population. And then from representative samples, about 25% of US adults report having sleep difficulties. And we know that these different dimensions of sleep health and sleep disorders are related to health outcomes, particularly quality of life, in addition to cardiovascular disease, cognitive decline, and even mortality. And there's some research that shows that that pathway may involve metabolism, inflammation, oxidative stress, and autonomic function, as well as others, but those are some of the main ones. And so, as I mentioned when discussing Healthy People 2030, we see that there's a high prevalence of sleep apnea among children as well. And so, and also we see that this prevalence is rising. So before 2014, about 3 to 9% was the prevalence of sleep apnea among children. Now, more recent rates are showing between 13 and 20%. So we're really seeing this increase, which very well could be due to increased screening. So that can happen. When you're screening more, you have a higher diagnosis, but it also could be a rise of other factors such as obesity and others that may be contributing to a higher prevalence of sleep apnea among children. And so I mentioned sleep health. So just to ensure that we're all on the same page in terms of the definition, I really like this conceptual framework that was put forward by Dr. Dan Bicey, which really thinks about sleep health as this multidimensional construct that is comprised of several dimensions, including sleep regularity, satisfaction, alertness, timing, efficiency, and duration. And I love that we can actually measure this. This is a scale. And depending on where people fall across these different measures, we know that it's associated with either better health outcomes or worse. And so throughout the presentation, when I mention sleep health, I'm typically talking about the sum of these different dimensions, and some of the work will focus on just a few of these dimensions. And so the acronym is RU SATED for the sleep health scale. And so, as I mentioned in the beginning, and talking about the points that I'll make during the lecture, it's important to know that sleep is truly a privilege. And so it is not equitable across the population. And so when I mention a sleep health disparity, this is the definition that I use. And so it relates to a difference in one or more dimensions of sleep health. So those that I mentioned in the prior slide, on a consistent basis that adversely affects designated disadvantaged populations. So we're not talking about just differences, but differences that are due to unjust and unfair circumstances. And so oftentimes we use race in these studies, but really race is being used as a proxy. Race is a proxy for social classification. And really what we're trying to measure is racism. So the different experiences that someone may have based on how they present. And so in some of the studies I'll show you, of course, we use race, and we're getting better in our measurements at this stage. But again, note that this is being used as a social factor, not genetic, and we're really using this as a proxy for social experiences in our race-conscious world. And so we see that historically minoritized individuals have a higher burden of sleep deficiencies, also have more severe sleep disorders, and we also see that they occur at an earlier age across the lifespan. And so we're talking about a longer duration of experiencing these different sleep disorders. And so here's a table from a paper that I published a few years ago with my colleagues, but it's still very relevant in terms of understanding the state of sleep within these different racial and ethnic groups. And so at the time when we published this, the data showed that American Indian and Alaskan Natives had longer sleep duration in comparison to non-Hispanic white individuals. But more recent data is also showing that there is actually a shorter sleep duration. But for other groups, we consistently see that Asian, Black, Hispanic, Latino, and Native Hawaiian and Pacific Islanders all have shorter sleep duration. And in a future slide, I'll quantify that difference. We also see that the sleep quality of Asian and Black individuals tend to be lower in comparison to non-Hispanic white individuals. But we see mixed data for Hispanic and Latino individuals, which goes back to my point about race as a social construct. And so it's really better to measure discrimination and so on. So we see that Hispanic and Latino individuals that have darker skin, their sleep tends to mimic those of Black individuals, whereas those with lighter skin, their sleep is closer to non-Hispanic white individuals. So that's why we're seeing some mixed data there. And then for sleep apnea, we see across these groups that there's more severe sleep apnea in comparison to non-Hispanic white individuals. And then we also see that for Hispanic Latinos, it's a little bit more consistent in terms of more severe insomnia, but the data are mixed for Black individuals. And there's been a number of qualitative studies that have sought to understand more about why we may see this. And from some of the work that my group has done, as well as others, we see that there's a lot of social stigma around reporting sleep in the Black community, particularly with the stigma around lazy. And so we see that Black individuals tend to underreport sleep problems, particularly insomnia. We even have data from Jackson, which shows that self-reported sleep is actually lower than actigraphy measured sleep, which is typically opposite of what we see in the literature. And so this is why it's also really important to have not only self-reported measures, but actigraphy and other objective measures for the dimensions that we can measure. So we know that insomnia it's typically only self-reported. And so in terms of quantifying what some of these differences may be, we see that there's about an hour difference in sleep duration between historically minoritized groups and non-Hispanic white individuals. But when we look at that intersection of both race and gender, we see that the differences can be quite larger than that. So for example, we see that Black men across studies have the shortest amount of sleep duration and white women have the highest. And so there's a difference between Black men and white women of about 2 hours. And so again, what I'm showing here is the average across. In terms of the prevalence of sleep apnea, there's differences between 5 and 86% higher odds of sleep apnea, depending on the population and the sample. And there's a study that showed that Black individuals in particular had twofold greater odds of severe sleep apnea and chronic insomnia in comparison to non-Hispanic white individuals. And then in looking at the insomnia with short sleep phenotype, which is really showing to be more severe than insomnia or short sleep alone, particularly in relation to cardiovascular outcomes, we see that Black individuals have about a 67% increased risk of that phenotype in comparison to non-Hispanic white individuals. And then overall, we see at a population level, there's limited data looking at sleep timing, but there are a few studies, and it shows that historically minoritized group have about a twofold greater odds of delayed sleep timing. And so it's important to think about what's driving these disparities among these groups. And so typically, in thinking about the fundamental causes of health disparities, we point to education and income. So let's take a look at some data supporting that. So here's a figure from some data that are a little old at this point, but still very relevant. And I'll show you some newer data. So this is data from the National Health Interview Survey of over 100,000 individuals that were included in this sample. And so here they looked at the prevalence of short sleep duration across different occupation groups. And we can think about these as proxies for socioeconomic status. So the highest group being the professionals, and then middle as the support staff, and then the lower SES as laborers. And here we have men and women, but the gradients are very similar. So we see a very different gradient for Black individuals, which are shown in the blue line, and Hispanic Latino individuals in the orange line in comparison to non-Hispanic white individuals shown in gray. And so we see that the prevalence of short sleep duration is highest among Black professional men and women, and their lowest prevalence of short sleep duration is among the laborers. And the same is shown for Latino individuals. It's just a lower prevalence overall. Now we see something opposite for non-Hispanic white individuals, where the lowest prevalence of short sleep duration is among the professionals, and the highest prevalence is for the laborers, and that's both for men and women. And so the greatest disparity that we're seeing is among those of higher socioeconomic status. And so this is really combating this idea that sleep problems is only among those of lower socioeconomic status. So this is why it's important to look at the intersection of various identities And so here we see that for Black individuals, it's really those that are of higher SES that are faced, at least in this example, with the highest prevalence of short sleep duration. And then when we look at the lower SES group, particularly the laborers, for women, we really see no difference, right? The prevalence of short sleep duration is very similar between Black women and white women that are laborers. And it's just a more narrow difference for men. And again, the gradient is similar for Hispanic Latino individuals. And so this is looking at occupation. So here's another example using more recent data. This is from 2020, looking at a different metric of socioeconomic status with focusing on education. But we see a very similar gradient. So white individuals are here on the left, Black individuals in the center, and Hispanic on the right. And so we see as education increases, the predicted probability of short sleep duration also increases for Black individuals. It's very similar for Hispanic individuals. There's a slight decrease that happens for those with greater than a college degree, but it's still higher than those with less than a high school education. And we see an opposite gradient among the white individuals in the study, where the predicted probability of short sleep is highest among those with less than high school, and it's lowest among those with a college degree. So these two studies show examples of how this gradient is different by race and ethnicity, with really pointing to those of higher SES as those who have the shortest sleep duration. So this shows that SES alone is not protective of adverse sleep health for minoritized groups, particularly for Black and Hispanic Latino individuals. And so typically, from research that we have seen outside of sleep, it has pointed to that income and education can afford us to live in better neighborhoods, have more access to health care and insurance, which should be associated with better sleep health outcomes. But what's missing here is how these different environments can expose people to different systems of oppression, which can lead to adverse sleep health outcomes. And so particularly these individuals tend to be minorities in these environments and exposed to more experiences of discrimination, microaggressions, and then there are different encounters with police brutality that are occurring, both vicarious as well as direct experiences. And so there are several determinants of sleep and circadian disparities that happen across the lifespan that are truly multifactorial. And so there are different social factors. I talked a little bit about discrimination and stress as contributors. And then a lot of my work sits with looking at different environmental factors. So thinking about the context in which people live, there could be different exposures such as noise and light pollution, particularly also air pollution, which can cause inflammation of the airway and lead to sleep apnea. And then there's these different sleep-related behaviors. And if we focus in on the individual, we can really miss the contextual factors that are giving rise to some of these behaviors. So take consistent bedtimes, for example. This could be the result of different policies, such as minimum wage. And so if someone works minimum wage, they may need multiple jobs in order to have a livable wage. And so they're not able to implement a consistent bedtime. These individuals are more likely to engage in rotating shift work. And if they have children, they may not be home in order to implement these consistent bedtimes. So if we just focused in on the individual in these times, we could be missing the contextual factors which shape these individual level behaviors. And so these can individually and cumulatively contribute to disparities in sleep health and disorders. And so here are just some figures that are really driving that point. The one on the left is one that my colleagues and I published a few years ago to really think about how individuals are nested within these broader contexts, which can shape individual behaviors, can also shape responses to different recommendations, sleep hygiene recommendations. And these individuals can live in what we call sleep deserts, which really have these different features that are really serve as barriers to being able to implement healthy sleep practices. And so that combined with other measures such as mistrust of the healthcare system and shift work and limited sleep opportunities can really shape our ability to engage in healthy sleep practices. And so here's a framework that I use for my work in thinking about historically and using contemporary measures how structural racism contributes to our current day environment. And so there were racist policies such as redlining, which really segregated neighborhoods and deemed some as worthy as investment and some as not. And that has lasted across time and generations and contributes to inequities in resource distribution, which lead to a differential access to housing, education, which are very connected. Our education system can dictate our trajectory for upward mobility and income, which can determine where we live, which again is a really a cycle that can keep some people impoverished. And also our differential access to wealth and the healthcare system. And that leads to these different features in the environment. And there are different responses. So these different stressors can get under the skin and cause a physiological response, particularly a stress response. And I'll focus today on chronic psychosocial stress. And then we also know that these can lead to adverse childhood experiences and affect our sleep and circadian health. And so here is a figure from a paper that my doctoral student published recently in this last year, where we looked at, this is among adolescents, where we were really trying to understand how or what factors may be explaining racial disparities. So the data that I showed earlier was mainly among adults, which showed that higher SES affects sleep among adults. And so here we looked at household level SES and found a very similar gradient. So for African American, American Indian, and Latinx adolescents in higher socioeconomic households, they were more likely to have short sleep duration. So in particular, we did a mediation analysis. So this is showing the results here. And we saw that household SES explains about 11% of the Black-white difference in sleep duration. For American Indian, it explained 10%. And then for Latinx adolescents, explains 42%. So that's a really large mediation. So this points to, one, there is something happening, some exposure, particularly perhaps stress, that is contributing to adverse sleep health outcomes among this population, and also showing this intervention point of the household and neighborhood. And so let's look at some data supporting stress as a contributor to sleep health disparities. And so overall, we see that minoritized racial groups have a disproportionate burden of psychosocial stressors. So in particular, these groups are more likely to report chronic exposure to stress and anxiety, more likely to have interpersonal and structural exposure to structural discrimination. And then they're also more likely to live in disadvantaged neighborhoods despite individual level income. And then for some groups, they're exposed to a cultural rate of stress, which there's data showing that that is associated with adverse sleep health. And then they're also more likely to experience a major life event. This could be the loss of a loved one, a spouse, loss of a job, or other traumatic, stressful events. And so we know that race and ethnicity can determine our experiences with psychosocial stressors that I mentioned in the last slide. And so from some of our work, particularly from some of our mixed method studies we've done, so we have both quantitative and qualitative data that supports this, so that we're seeing that rumination is likely on this pathway. So in particular, individuals speak about, in our studies, this is among Black adults, speak to these different experiences of discrimination and microaggressions they have during the day. And then at night, they tend to ruminate, think about how they should have responded, or just replay the events in their minds. And we can see that that's related to a longer sleep latency, also increased arousals that are happening at night. And we've done formal mediation tests to support that. And so we know that that can affect and lead to sleep deficiencies and sleep and circadian disorders. And within the realm of what I do, how that also contributes to adverse cardiometabolic health. And so here's just an example from some of the mediation work we've done, where we've looked at specifically racial discrimination as explaining 57% of the Black-white difference in insomnia severity. And so again, pointing to this idea that different race salient stressors are likely intervention points to reduce sleep disparities. And so here's some data from a epidemiologic cohort study called Cardia. And so here I looked at, my colleagues and I looked at chronic burden. So this is moving beyond just stress, but how much of a problem or burden are these different stressors you have experienced over the last 6 months? And how does that relate to sleep by race? And for this particular study, we found that for Black individuals only, not white, experiencing a medium or high chronic burden was associated with a shorter sleep duration by self-report, less than 6 hours. And also, it was associated with a worse sleep quality score as measured by the PSKI. There was no associations with actigraphy measured sleep duration or sleepiness, but the associations we did find were only among Black individuals and not white individuals in this study, which again is showing that there's something about these stressors that are unique to Black individuals in particular that may be contributing to adverse sleep health. And so the last few years, we've done a really nice job of documenting disparities. And we are moving more into understanding some of the determinants of these different sleep disparities. And so where we're also really trying to move to is, how do we then intervene? What is the intervention to improve sleep in these different communities, and thinking about all the multi-level stressors that they face in day-to-day life. And so I'll go into giving you some empirical data around the work that we're doing to understand how to intervene, and then testing an intervention. And so we conducted some focus groups among Black individuals in Atlanta. Atlanta is a very unique place in having a very diverse socioeconomic a gradient across Black individuals. So meaning there is a very high percent of Black individuals in Atlanta that are higher SES, as well as a portion that are of lower SES. So we're able to look at the factors by socioeconomic status. And so from these focus groups, we asked participants about different facilitators and different barriers. And so some of the most common barriers that were identified were stress, anxiety, rumination, feeling unsafe, and past traumas. So these are reports from individuals who talked about these as barriers to why they're not engaging in healthy sleep practices. And this did vary by gender. I don't have time to get into that data, but I'm happy to talk about it. And so, in thinking about some of those data and from other focus groups, we started thinking more about meditation strategies. And so we know from the literature that meditation can potentially decrease stress, help to manage anxiety. It can improve sleep quality. But we also noticed that there were a number of gaps in the literature. So many of these studies were conducted in very homogeneous populations that were mainly non-Hispanic white individuals, so they lacked diversity. And then in thinking about digital divides and trust, we're just really not sure how feasible these different intervention strategies are among racially minoritized groups. And then again, my research focuses a lot on cardiovascular health. We were really interested in understanding if we could intervene on sleep, could this potentially also have a subsequent positive impact on cardiovascular health? So this is a feasibility study that we conducted called MINDS. And so the idea was to improve sleep and diabetes risk via a mindfulness and sleep education intervention. Now, this was conducted during the pandemic, so we had to adjust some of our outcomes. And so we weren't able to bring individuals in, so we changed some of the cardiometabolic outcomes that we looked at. So we enrolled 18 men and women who were 18 years of age or older that lived in Metro Atlanta. Our eligibility criteria included those that had poor sleep quality, with again using the PSCI. Then we conducted a 30-day mindfulness intervention, which I'll go through the details of that, and also did a one-time sleep education seminar to discuss healthy tips. And then across time, 35 days, they wore an active watch to measure actigraphy. So a few days before the intervention, during the intervention, and then we collected it at the end. And then we also dropped off scales and blood pressure monitors at their homes to measure weight and blood pressure before, midpoint, and after the intervention. And then we did a number of questionnaires. And so we used the Headspace app, which was really great for conducting research because we were able to get the data from Headspace regarding how long people were on the app and which modules they completed. And so we instructed participants to do about 10 minutes of mindfulness a day in the evening when they were starting their bedtime routine. And so they specifically focused on, in the beginning, how to do mindfulness breathing. And then they did specific modules on managing anxiety and letting go of stress. And so then we use this healthy sleep practices framework that was utilized in a study that I was a part of in Boston. And so this is published, where we really just talked about different healthy sleep practices and just gave them this framework to think about which activities are okay at what part of the day. So really encouraging them to get light first thing in the morning, having a dark environment towards the evening, having their caffeine and naps during the day, and stopping that, as well as alcohol close to bedtime. And so in terms of the protocol, so I mentioned we measured these different cardiovascular factors in actigraphy pre-intervention. And then a few days later, they had an intervention visit where we went over the Headspace app, how to install it on the phone, and how to utilize the different modules. And then I gave the sleep education seminar. And then during the midpoint, we dropped off the scales and blood pressure, also pushed some questionnaires to them to complete, did the same 15 days later at the end of the visit. So that comprised the 30 days of mindfulness. And then we did focus groups to understand their experience via Zoom after the intervention. And so again, this was a feasibility study. So it's a smaller sample of 18 individuals, but we enrolled mainly individuals that were from historically minoritized groups. Black, Asian, and Hispanic was the majority. The sample was also mainly female at 89%. And again, going back to that interest and understanding factors related to individuals of higher SES, the sample was mainly comprised of those with a bachelor's degree or higher. And so, but regardless of that, about 50% of our population still had an income less than 50,000, which also speaks to this idea of education and income not being related among historically minoritized groups. So of higher education, they tend to get paid less than their white counterparts. So in terms of app usage, we saw that the average number of sessions completed was about 37, which is great. The average number of days that people engaged on the app was 23. We asked them to engage around 30 days. And then overall, they spent about 9 minutes on average on the app, and we asked for 10 minutes. So this is pretty good. And so about only 33% were adherent for all 30 days. And so, so here are some of our results. So we did see a change in stress levels. So this shows the distribution of stress before the intervention in blue and after the intervention in orange. So we see this lower percent of individuals in the high stress group after the intervention, more in the low stress group, which is great. And then in terms of the change in sleep quality, we did see a change in the PSKI greater than 5, which is the indicator of poor sleep quality. So we saw at baseline, there was about 67% that had a PSKI greater than 5. And then at follow-up, only 39% of our sample had a PSKI greater than 5. So they decreased in the PSKI, which means improvement in sleep quality. There wasn't really much of a change in sleep duration, but we do see that there's this difference in self-reported sleep duration. Actigraphy measured sleep duration, a large difference. So at baseline, it was about 8 hours self-reported, but when we measured, it was actually 6 hours. So we saw a big difference here, but there was a slight increase, but still there's really no difference here in sleep duration. But our focus is really on sleep quality. In terms of sleepiness, we used the Epworth Sleepiness Scale. We saw a decrease, which means an improvement. So an average score is 6.1 before the intervention and 5.7 after. And so then we also looked at adherence by these different metrics of stress, the PSKI, sleep duration, self-reported actigraphy, and there's really wasn't much of a difference there in terms of adherence. So we generally saw this benefit regardless of how much they engaged on the app. And so while we didn't expect to see any cardiovascular measures, we actually saw that there was some benefits. And so we saw at follow-up, the prevalence of obesity decreased from 50% to 35%. And then we saw more individuals that were in the normal blood pressure range. We started at 78%, and at follow-up was almost 89%. So overall, this, again, an individual level intervention. We saw that mindfulness was related to a decrease in stress and anxiety, an improvement in sleep quality, and an improvement in cardiovascular health. And so, as I mentioned, we did some focus groups after to understand their experiences, and there were some really interesting takeaways, which included most of the individuals saying that they wanted a guide that was of the same race and gender. And so in thinking more about that, we did some additional focus groups to understand more about how we can improve the intervention. And so in these focus groups, again, these are Black adults in Atlanta. We asked just what did they know about sleep health recommendations? What are some things that they should do? And so we saw overall women were the ones that were more likely to report engaging in things or hearing about these things. This doesn't mean that they actually did them. Engaging in calming techniques as an avenue to improve sleep. Limiting electronic use was common across all the groups. But then for men in particular, they reported some environmental factors such as listening to white noise or dimming lights before bed or seeking a professional, which was not reported for women. And then we also had a few individuals that were gender nonconforming, which specifically mentioned about reducing exposure to blue light. And so we asked, how do you want information about sleep? What would be the avenues? And so overwhelmingly, so on the top here shows the source of information that was reported. But mainly, individuals talked about wanting to get information about their sleep and healthy sleep practices from social media. And they talked about being more likely to listen to social media influencers as opposed to doctors or professionals. And also in that conversation, a lot of ideas around mistrust came up and how going to the doctor also caused some stress. Individuals talked about ruminating and having to prepare for their doctor's appointment. So it's consistent with wanting to hear information really from social media. And so when we talked about these different ways, they really wanted the information through videos or infographics. I mentioned social media, in-person discussions, and pamphlets. But what was even more interesting about this, they talked about when getting this information, they wanted it racially tailored. They want to see individuals that look like them that are on these pamphlets, that are communicating these results. And this is very consistent with the data that was published from about the racially tailored shut-eye program or intervention, which just changed the physicians and patients to being Black. And they found that the individuals in the study that were in the racially tailored shut-eye were more likely to be engaged. They also talked about wanting brief messages, emphasizing the importance of sleep, and then specifically designing this for lay audiences. So not being too, having a lot of jargon or medical terms. And then it should be widely disseminated. And so I want to end with just putting up this figure, which really speaks to, our need to move upstream in understanding how to improve sleep and really to address sleep inequities. So while we're here, they didn't add sleep here, so I added it, and looking at these individual level behaviors, yes, the interventions that we did were at the individual level, but the idea was really to combat some of the issues that they're facing in the workplace and within these living conditions. But it's really time for us to start moving upstream in terms of our interventions. So in summary, we see that there are racial and socioeconomic disparities in sleep, and there are multi-level determinants of these different disparities. And in particular, we see that the minority stress model is very prevalent and is really, really shaping some of these different experiences. So more specifically, and pointing to how we all experience stress, but individuals from minoritized groups experience a stress that's more chronic and additive to everyday stressors. And so that those unique stressors that are particularly racially salient need to be addressed. And so targeting stress in these populations may help to improve sleep in these groups. And then again, multi-level and tailored interventions are needed. And we know from other fields that racially and culturally tailored interventions are more effective within these populations. So I just want to acknowledge some of my co-authors and my research group, as well as the funders for the different data that I shared today. So we do have 5 minutes, and I would love to engage in some questions and comments if you have any.
Perfect. Thank you so much, Dr. Johnson, for this excellent talk
Awesome.
on this really important topic. I have a quick question or comment. You showed that the sleep duration was different in different ethnic group, because of different socioeconomic backgrounds and system of operation. Certainly, socioeconomic background is not something, we can change, but perhaps in terms of system of oppression or other factors, is there one thing or anything that we can focus as physicians in our clinic to help with, besides or amongst the ones that you suggested?
Yeah, really great question. And I actually have this slide that talks about what clinicians could do. And some of this is about understanding who is most at risk. And so just knowing someone's address can be actually more important than knowing their genetic code. So being able to identify where someone lives, which may dictate how you may need to adjust different recommendations you give. So for example, in our work in lower SES environments, we did learn that these individuals are more likely to sleep with a television on. And it's not because they just want to watch television. We actually learned that this was a safety measure. This allows someone to know that someone's in a home. So if someone is coming into your practice and they mention that they do sleep with the lights on, so just telling them to turn it off is not going to be effective or efficient. Really, it could cause more vigilance. It may cause more trauma. So we're really at a point where we have to think about what are some ways in which we can adjust our sleep hygiene or healthy sleep practices to have the best uptake across these different populations. So you asked for one thing, and then I talked about others, but really measuring things like social determinants and understanding the context in which people live. And I'll just end with one other thing and take another question. But for example, having someone come to a sleep clinic for an overnight study just may not be advantageous. It may cause a loss in money for them. It could also cause a burden with children. So being able to utilize things like mailing in-home devices, it would be better off, right? As opposed to suggesting someone come and then they never come, right? And then we just say, oh, people of color don't adhere to these recommendations, but we're not thinking about the context.
Yeah, very true. Great. Thank you so much.
You're welcome.
I have one comment from Dr. Tobias, Lauren Tobias. Thank you for a wonderful talk as always. Dr. Johnson, you're doing such important work.
Well, thank you.
And if anyone has any question, please feel free to unmute yourselves. You can unmute yourselves or raise your hand or put the question in the chat room.
I have a question.
Sure.
So first, I want to
Hi,
congratulate you. Hello. Hi, Dr. Johnson. I want to congratulate you on such a wonderful talk. It was a tour de force. As another individual who's very interested in stress, I'm curious about the data from your feasibility study, and you show the change in stress. And obviously, as you mentioned, recurrently, there are some stressors which are more impactful and some which are obviously occur in childhood, which affect us throughout our lives. And I'm wondering how stress was defined, which questionnaires you used, and if that is just based on the perceived social stress scale, or if you have data concerning individual type of stressors.
Yeah, great question. And thank you so much for the kind words. So we used the perceived stress scale, the Cohen perceived stress scale, as our primary outcome. But we also measured, which I didn't share, we measured race salient factors. And we've published some of these. I'm happy to share the citations. So we also use what's called the race-related event scales. And so this specifically measures experiences that may cause stress based on how you present. And so it's similar to discrimination, but it's so to the everyday discrimination scale, but it's more current in terms of experiences, and also speaks to both direct experiences and vicarious. It also ranges between violent acts and nonviolent acts. And so that's the race-related event scale. And then we also measure discrimination with the attribution scale. So they're able to say this happened because, again, going back to this importance of intersectionality, was it your race or was it your gender? Or was it because of your disability or health status? So we have those attributes. And we also hear a lot specifically from the women in the study that talked about, I don't know if it's because of my race or if it's because of my gender, and for some, is it because of my age? So we do see differences there, but we measure all of those.
Thank you so much. I'd be interested in some of that data if you were
Oh,
interested
absolutely.
in chatting about that. So
Yeah,
thanks,
yeah,
Dayna.
definitely.
Great. I don't see any other questions. Thank you so much again for this wonderful talk. And thank everyone for joining.
Thank you
Bye-bye.
again for the invitation.
Thank you. Bye.
Bye.